Erythroderma. It's a mouthful, isn't it? But behind this complex name lies a serious skin condition. Imagine your skin from head to toe engulfed in fiery redness. Now picture intense scaling like 1,000 tiny snowflakes constantly shedding. That's the stark reality of erythroderma, also known as exfoliative dermatitis. This isn't just a cosmetic concern. Erythroderma is a medical emergency. It disrupts the body's natural equilibrium, impacting everything from temperature regulation to fluid balance. As dermatology experts, you know that early recognition and intervention are crucial in mitigating potential complications. Think of erythroderma as a distress signal. It's our job to decode that signal and identify the root cause. Is it an underlying skin condition, a medication reaction, or something more sinister? This lecture will equip you with the knowledge to navigate the complexities of erythroderma. Together, we'll delve into the latest research, explore diagnostic strategies, and discuss effective treatment options. Because in the world of dermatology, knowledge is power. And when it comes to erythroderma, that power can be life-saving. Erythroderma might be rare, but it can strike anyone at any age. While the exact incidence remains elusive, we do see some patterns emerge. Men, for instance, seem more susceptible than women. And as we age, the risk of developing erythroderma increases, often linked to underlying health conditions. But what triggers this dramatic skin response? The truth is, there isn't one single answer. Erythroderma is like a chameleon, often camouflaging itself as other skin conditions. In fact, pre-existing dermatoses are the most common culprits: psoriasis, atopic dermatitis, seborrheic dermatitis. These familiar foes can sometimes escalate, morphing into erythroderma. And let's not forget drug reactions. Medications like allopurinol, sulfonamides, and even some antibiotics can trigger this severe reaction. Then there's cutaneous T-cell lymphoma, a type of blood cancer that can manifest as erythroderma. And as if the picture wasn't complex enough, systemic illnesses, from autoimmune disorders to certain cancers, can also enter the scene. And then there are times when, despite our best efforts, the cause remains a mystery. These are the cases of idiopathic erythroderma where the trigger remains elusive. But even in these situations, we don't give up. We investigate, we manage, and we support our patients through every step of their journey. Erythroderma isn't just skin deep. It's a systemic inflammatory storm that throws the body's delicate balance into disarray. At the heart of this storm lies the immune dysregulation. Imagine your immune system, normally a well-coordinated defense force, suddenly going haywire. And that's what happens in erythroderma. T-cells, the sentinels of the immune system, become overactivated, launching an all-out attack on the skin. This triggers a cascade of inflammatory mediators, flooding the body with cytokines like IL-1, Illinois-6, and TNF-A. The skin, once a protective barrier, now becomes a battleground. The assault weakens its integrity, leading to increased water loss and a compromised ability to regulate temperature. It's like your body's natural thermostat has short-circuited. But the damage doesn't stop there. The systemic effects of erythroderma can be far-reaching. The widespread vasodilation, a desperate attempt to dissipate heat, can overload the heart, leading to high-output cardiac failure. Meanwhile, the constant shedding of skin cells results in significant protein loss, causing hypoalbuminemia. Electrolyte imbalances and dehydration further compound the problem. In essence, erythroderma pushes the body to its limits, demanding our immediate attention and intervention. Imagine examining a patient whose skin is ablaze with erythema, covering over 90% of their body. This intense redness isn't just a rash, it's a beacon, signaling a state of erythroderma. But the redness is just the tip of the iceberg. As you look closer, you'll notice scaling. The type of scaling can offer clues about the underlying cause. Fine scales might point towards psoriasis, while thick, plate-like scales could indicate pityriasis rubra pilaris. Edema, particularly in the extremities and face, is another telltale sign. This swelling, caused by fluid leakage from inflamed blood vessels, further distorts the patient's appearance. Chronic cases may also present with lichenification, a thickening and hardening of the skin, and painful fissures. But the clinical picture extends beyond the skin. Patients with erythroderma often complain of systemic symptoms like fever, chills, and a general sense of malaise. Lymph nodes might be enlarged, especially if the erythroderma is linked to malignancy or drug reactions. The intense itching, often described as unbearable, can disrupt sleep and significantly impact quality of life. And because the skin's protective barrier is compromised, secondary infections, particularly with Staphylococcus aureus or fungi, are common complications. In Section 5, Unraveling the Mystery Diagnostic Protocols for Erythroderma. Diagnosing erythroderma is like piecing together a complex puzzle. It starts with a thorough history and physical examination. We need to delve into the patient's medical past, their family history, any medications they're taking, and even recent travel or exposures. Laboratory tests are our next line of investigation. Basic blood work, including a complete blood count, liver and kidney function tests, and electrolyte levels, helps assess the extent of systemic involvement. Depending on the suspected cause, we might order more specific tests. Elevated IgE levels, for instance, could point towards atopic dermatitis. A peripheral blood smear might reveal Sézary cells, characteristic of a specific type of CTCL. But the cornerstone of diagnosis is often a skin biopsy. Examining a small sample of affected skin under a microscope can reveal telltale signs. Psoriasis, for example, presents with parakeratosis and Monroe microabscesses. CTCL, on the other hand, shows epidermotropism and Portrier microabscesses. Imaging studies like a chest X-ray or CT scan might be necessary to rule out malignancy-associated erythroderma. In some cases, more specialized tests like flow cytometry to quantify Sézary cells or patch testing to identify contact allergens might be warranted. Remember, diagnosing erythroderma isn't just about confirming the presence of the condition. It's about identifying the underlying cause. This detective work is crucial in guiding our treatment approach and, ultimately, improving patient outcomes. Section 6, playing detective differential diagnosis of erythroderma. Erythroderma presents a diagnostic challenge. It's like a red herring in the world of dermatology, mimicking a range of other conditions. Our job is to differentiate erythroderma from its imposters, ensuring accurate diagnosis and appropriate treatment. Let's start with primary dermatosis. Psoriasis and atopic dermatitis, two common inflammatory skin conditions, can sometimes escalate into erythroderma. Distinguishing between them requires careful examination of the clinical presentation, distribution of lesions, and histopathological findings. Drug reactions are another potential culprit. Stevens-Johnson syndrome and toxic epidermal necrolysis, severe adverse drug reactions, can also manifest with widespread erythema and scaling. However, these conditions often involve mucosal surfaces, a key distinguishing feature from erythroderma. Infectious agents can also mimic erythroderma. Staphylococcal scalded skin syndrome, often seen in children, causes widespread blistering and desquamation. Erythrodermic scabies, a severe infestation with the scabies mite, can also present with intense redness and scaling. Malignancies, particularly cutaneous T-cell lymphoma, warrant special attention. Sézary syndrome, a leukemic variant of CTCL, often presents with erythroderma, lymphadenopathy, and circulating Sézary cells in the blood. Other malignancies, like Hodgkin's lymphoma, can also manifest with erythroderma. Distinguishing between these conditions often requires a combination of clinical suspicion, histopathology, and specialized tests like flow cytometry and lymph node biopsy. Remember, the key to successful differential diagnosis is a combination of vigilance, a systematic approach, and a willingness to consider all possibilities. By carefully analyzing the clinical presentation, laboratory findings, and histopathological features, we can confidently differentiate erythroderma from its mimics and ensure appropriate management. Section 7. A multifaceted approach treatment and management of erythroderma. Treating erythroderma is like conducting an orchestra, coordinating multiple interventions to restore harmony within the body. It requires a multifaceted approach, addressing both the underlying cause and the myriad of systemic complications. Hospitalization is often the first step, providing a controlled environment for close monitoring and supportive care. Fluid and electrolyte management is crucial, as dehydration and electrolyte imbalances are common. We carefully monitor urine output, replace fluids intravenously, and correct electrolyte derangements. Temperature regulation is another priority. Erythroderma disrupts the body's thermostat, making patients prone to hypothermia. Maintaining a warm, humidified environment helps prevent heat loss and promotes comfort. Nutritional support is essential. The constant shedding of skin cells leads to protein loss, while the body's metabolic rate increases to combat the inflammatory process. A high-protein diet, sometimes supplemented with enteral or parenteral nutrition, helps counteract these losses. Topical therapy plays a crucial role in managing the skin manifestations of erythroderma. Emollients and moisturizers soothe the skin, reduce dryness, and help restore the compromised barrier function. Low to medium potency corticosteroids provide anti-inflammatory effects and alleviate itching. Systemic therapy depends on the underlying cause. For erythroderma triggered by psoriasis, systemic retinoids, methotrexate, or biologics like IL-17 inhibitors might be indicated. Atopic dermatitis-related erythroderma might respond to cyclosporine or dupilumab. Drug-induced erythroderma requires immediate discontinuation of the offending agent. Systemic corticosteroids might be necessary to control severe inflammation. CTCL-related erythroderma often necessitates a combination of therapies, including phototherapy, PUVA, systemic retinoids like bexarotene, and immunomodulators like interferon alpha. Idiopathic erythroderma, while challenging, often responds to a trial of systemic steroids while we continue to investigate the underlying cause. Throughout treatment, we remain vigilant for secondary infections. Prophylactic antibiotics or antifungals might be necessary, especially in hospitalized patients. Remember, treating erythroderma isn't just about addressing symptoms. It's about restoring the body's equilibrium. By coordinating supportive care, topical therapy, and systemic medications tailored to the underlying cause, we can guide our patients towards recovery and improve their quality of life. Section 8, looking ahead, prognosis and follow-up for erythroderma patients. The prognosis of erythroderma depends on the underlying cause. Cases triggered by drug reactions often resolve within weeks after discontinuing the offending medication. However, erythroderma associated with CTCL carries a more guarded prognosis, requiring long-term management and close monitoring for disease progression. Follow-up care is essential for all patients with erythroderma. We monitor for recurrence or progression of underlying skin conditions, adjusting treatment plans as needed. Routine blood work helps assess for systemic involvement and monitor for medication side effects. Patient education is paramount. We empower our patients with knowledge about their condition, potential triggers, and the importance of adherence to treatment plans. We encourage them to be proactive in managing their health, reporting any new or worsening symptoms promptly. For patients with chronic conditions like psoriasis or atopic dermatitis, we emphasize the importance of long-term management strategies to minimize the risk of erythroderma flares. We discuss lifestyle modifications, stress reduction techniques, and the role of support groups in coping with their condition. Remember, our role as healthcare providers extends beyond treating the immediate crisis of erythroderma. By providing ongoing support, education, and compassionate care, we can empower our patients to navigate the challenges of their condition and live full and meaningful lives. Section 9, Conclusion Collaborative Care for Erythroderma. Erythroderma isn't just a dermatological condition, it's a systemic inflammatory storm that demands a coordinated and comprehensive approach. As dermatology experts, we play a crucial role in leading this effort, collaborating with colleagues across specialties to ensure optimal patient outcomes. From the initial diagnosis to long-term management, our approach must be patient-centered, focusing on the individual's unique needs and concerns. By combining the latest scientific advancements with compassionate care, we can navigate the complexities of erythroderma and make a tangible difference in the lives of our patients. Remember, erythroderma is a journey, not a destination. By working together, sharing our knowledge and advocating for our patients, we can light the path towards recovery and empower them to reclaim their health and well-being. Thank you for your dedication to the field of dermatology. Together, let's continue to unravel the mysteries of erythroderma and provide hope and healing to those affected by this challenging condition.